Okay, here's our introduction to the fourth module. We're going to talk about bone. What's really great about bone is that as a tissue, it heals a lot better than every other tissue we've talked about when we have kind of talked about all these different post-operative situations. So that's kind of exciting. When we think about bone healing, we think about this guy named Julius Wolff, who lived from like 1836 to 1902. And he first described this idea of bone adapting to load way back in the 1800s. And it's really helpful to understand how important load is for bone and understand it scientifically. So we talked about every tissue needs to be loaded. Okay, if you get nothing out of any of these classes, the most important thing is that we need any tissue to be loaded and loaded in certain ways, specific ways, to help with the healing process. So Julius Wolff was studying these things. I think he was studying them related to animals and different, not just people, during the 1800s. And it's a really important concept for us to understand that bone is going to adapt to the loads that are placed on it. And so that's usually some sort of mechanical stress that would include muscles, it would include body weight, all of those important things. So not only will bones get stronger when we increase the load, but bones will get weaker when we decrease the load. So this is called mechanotransduction. At a cellular level, it's basically the mechanism that basically says that cells convert some sort of mechanical stimuli, again, body weight, muscle, whatever it is, into a response depending on the load. So this happens through communication between the cells, some sort of coupling that occurs. And so, again, we just have to recognize that by doing these things, we're literally kind of waking up these cells to put extra pressure, literal pressure, on the cells to do something. So in the case of bone, the cellular makeup is a large amount of osteoblasts. So osteoblasts form, maintain, and basically allow for mineralization of the matrix of the bone. Osteocytes are what sense that mechanical force, and then you have what are called bone lining cells, which maintain the homeostasis of the minerals within the cells. The osteoclasts are the ones that come in and remove pieces, the bad part of the bone cells, and kind of reabsorb them. One of the most important things to recognize is that those osteocytes are the ones that sense that mechanical force. So this is what therapy is all about, is we want to stimulate those osteocytes, okay? They're going to help to trigger the events that allow for bone to heal. And that's something that we will definitely need to think about doing with our treatment. So this is the most exciting thing about bone. Bone has great blood flow. Bone is highly vascular. And if you remember when we talked about cartilage, a lot of cartilage does not have good blood flow. Ligaments, certain parts of ligaments and certain parts of tendons do have good blood flow, but not all of it. But bone, we are very lucky because bone has great blood flow, okay? There's a lot of capillaries, there's a lot of areas throughout the bone that are getting good nutrients from blood. So this allows healing to happen very well in bones, okay? Bones can heal really well because we have good blood. However, we have to recognize that there are situations where fractures can disrupt the blood supply, okay? So we've heard of avascular necrosis. Avascular necrosis happens when a fracture or some sort of trauma has stopped the blood flow to a certain area of bone. We also have to recognize that certain bones, there are certain areas that have less blood flow. So when we talk about something like the scaphoid in the wrist, there's a certain part of the scaphoid that doesn't have good blood flow. And so when we have fractures, that's a complication that can happen at the scaphoid or the femoral head. We talk a lot about avascular necrosis at the femoral head because that can happen with a fracture or some sort of trauma. So this is kind of, I think, high school science. We know that there's different types of bone. There's cancellous bone. We also call that compact bone. I'm sorry, those are two different things. Cancellous bone or compact bone. Cancellous bone is going to be the spongy, more airy bone, essentially. And that's where there's more surface area. And in theory, there's probably more blood flow in the cancellous bone. And then compact bone is more dense. It's 4 times more dense than cancellous bone. There's still good blood flow there, but it's just made up of a different matrix. So microscopically, you'll see that the bone itself can be more woven, which is that top picture, or the top like thing in the picture, that's the woven bone. And then you can also, and this one is more disorganized. So this is just like when you think of ligaments and tendons, we know that when they're first putting down their, that collagen, that it's disorganized, right? That it's more of that crosshatch or kind of not straight lines. But as things start to heal and they become more organized, then it's just like with the ligament and tendon, you can get what's called lamellar bone. And that's going to be that more parallel lines, much more, it looks better. It looks cleaner. So here's a picture to show demonstration of that, the difference between the compact bone, and then in this case, they call it the spongy bone. So obviously there's a lot more surface area. There's a lot more holes in the spongy bone. This isn't a long bone. With long bones, the spongy bone is going to be proximal and distal, and the compact bone is going to be in the middle. So that's important to think about when we think about the mechanical properties of bone, because we need to be able to recognize that bone is going to take on load, right? That's a huge part of, and so a huge part of what the bone does. So it takes on stress. Different types of bone are going to respond to stress differently. And so we have to recognize that depending on if it's the cortical bone, which is that the more solid bone, it's going to be more stiff. So it's going to be able to take on more stress. So the picture and the example that we see is usually with the femur. So here's a picture of the femur. And you can see that the cortical bone is much more straight up and down. So again, you can apply pressure straight up and down and it's going to stay very solid. The cancellous bone, however, or the trabecular bone, is along the head of the femur, right? The head and the neck of the femur. That's designed more for energy storage. So we can hold our energy in those parts of the bone. But again, it's not quite as stiff or stable. So when we talk about fractures, when we talk about hip fractures, things like that, we know that those are the areas where we're much more likely to get a fracture. So let's talk about these different kinds of fractures. What happens? We end up with destruction of the matrix of the bone. You can also disrupt the vascular supply. And that doesn't always happen. It depends on the fracture. And then you could end up with instability, again, depending on the fracture. So you have what's called a simple fracture versus a compound fracture. Simple fractures are where the skin stays intact, so it's not pushing through the skin. Compound fracture is where it actually punctures and goes through the skin. To show you different kinds of fractures, that top right is what's called a green stick fracture. It's you'll see it's kind of going through that more solid bone. And it's not the worst kind of fracture in the world, but it does cause some instability. A transverse fracture is going straight across in the transverse plane, so that makes sense. So it's going straight through, kind of perpendicular to the line of the bone. And a spiral fracture is just that. It's a twisting type of motion that's led to the fracture. So so that would be where maybe if you planted, I mean, this doesn't happen very often. This would have to be like a significant type of force on your leg, but like where you plant your foot and twist, that would lead to some sort of spiral fracture. Compression, oh, sorry, that's not a compression fracture. Sorry about that. That's oblique fracture. That's so interesting. That I should have changed the words on that one. Sorry about that. So an oblique fracture is where there's a rotation and you'll see kind of a diagonal fracture there. So a compression fracture is here. Compression fractures tend to be common. We'll talk about compression fractures of the spine and compression fractures of other bones like the tibia, bones of the feet, those kinds of things. So compression fracture literally means that there was compression, and so it kind of explodes from the middle of the bone. So fracture healing, our healing process, you start off with what's called primary healing, and then you have secondary healing. So primary healing is when there is some sort of rigid fixation with minimal gapping of the fracture site. So this is essentially, if you were to do an ORIF, if you were to put some sort of hardware into around the bone or in the bone to help stabilize it. So it's going to give you that rigid fixation. And so basically when you do that, then there's very little gapping between the two bones, and so the bone can form in between. So it's going to remodel the lamellar bone, which has what's called Haversian canals, and it will be able to bring in the blood vessels. So the blood vessels are still there. They're just going to now connect to each other again. Initially, you're going to start with lamellar bone. So even with these ORIFs where you have a pretty stable healing site, I guess you would say, the lamellar bone is going to lay down perpendicular to the long axis, so it's not very strong. So again, this tissue looks like other tissues that we talk about during that initial phase. As it's initially laying down tissue, it's not terribly strong, and it's not lining up very well. With this primary healing, this first part of the process usually takes 3 to 8 weeks. And we'll talk about specific bones and the amount of time it takes depending on the bone, but it can be anywhere from 3 to 8 weeks. But usually by 8 weeks, usually by 8 weeks, you have that first primary healing is completed. So these are some examples as we talk about different things like hip fracture, proximal humeral fracture. We'll look at a lot more of how this primary healing happens. So you see the bone fractures are being stabilized using some sort of hardware. Here's another one. So again, this is hip fracture. In this case, they're using screws. You can see the fracture on the far left, and then the different angles of the picture of using these screws to stabilize the head and the neck of the femur. So secondary healing is where nothing is moving and you actually have inflammation. So this is the case where you may not have the hardware there. And so with this type of situation, you're immobilizing the bone, wherever the bone might be. Inflammation then causes a hematoma to form, and inflammatory cells start to come in and allow for healing. So the process is going to be a little bit different because you're going to have soft callus formation, which is a combination of bone and different tissues, including cartilage. And so the soft callus develops first, and then a hard callus develops, and then at the end you get bone remodeling. So this is a picture of what it looks like, and we're going to go through this process in a little bit more detail. So this is happening with primary healing as well. It's just it's happening more quickly. So this is really showing how this could happen without all the hardware there. for the bone to grow around. So again, we'll talk about each stage all the way through. In this case, they kind of ended at day 35, but you'll see that hematoma, that blood is in the first couple of days, and then the soft callus is from day 5 through about day 16 or so, and then the hard callus is from day 16 on. So again, this is just another picture showing hematoma formation, and then soft callus, bony callus or hard callus, and then remodeling. So let's go into a little more detail. Inflammatory cells are moving into the area. During this period, you could definitely have inflammation, which means you have pain. So if you are seeing swelling around the area of the fracture, that's normal, okay? That's a normal process. We know that inflammation is a normal process of healing. Into the fibrocartilaginous callus formation, this is usually happening, like I said, through 5 days or so after a fracture. And this is where we're getting that combination of bone, some fibrous tissue, and cartilage. And we're getting all of that happening because new blood vessels are forming to bring in all that stuff. Bone callus formation is going to happen after that, so usually at 2 to 3 weeks. And the cartilage that was there is now being replaced by bone. So actually this says 3 to 4 weeks after the injury and continues until 2 to 3 months. And so we started off with that woven bone, and that's what's gonna that's what we're gonna see during this period of time. So we're getting rid of the cartilage. We're bringing in this what we call kind of callus, which is bone. It's bone tissue. It's not cartilage anymore, but it's not very well defined. It's not very well organized. And that type of bone is going to continue. Again, it depends on the bone, but it usually continues for 2 to 3 months after the fracture. And then after that, we get the bone remodeling. So most doctors, when they are deciding when you can, really start doing full-on activity, they're usually going to say it's during those first phases. Bone remodeling occurs over a year, sometimes more than a year. And so this is the situation where we're still, the bone is still healing, and we're definitely getting more of that sort of beautiful bone to come in, and the right tissue is laying down to make this a very, very strong healing space. But that strength is continuing to occur basically over a good 6 months up to a year. After, on an x-ray, it's showing that it's healed. So an x-ray, again, at 2 to 3 months, is going to show that most, unless there's complications, most bones are healed. But remember, we're still getting remodeling after that. And what's great about most bone, again, if there isn't complication, is that bone heals stronger than the bone was before the fracture. So that's the opposite of the other tissues we've talked about. Tendon, which we just talked about, ligament, and cartilage, if there's an injury to those tissues, they're going to heal weaker than the original tissue. But bone actually heals stronger than the original tissue. So that's awesome to see. And you can see that. So this is a fracture, tib fibular fracture, kind of distal tib fibular fracture. And you can see from at 1 month that we're starting to see that bone bridging. And then at 2 months, there's significant bone bridging, and it's almost thickened around the area of the fracture. And that's exactly what happens if you just let a fracture heal on its own. So what's really important for us to understand? Healing times, okay? Depending on location, depending on the bone, there are different times for healing. For fingers and toes, 3 weeks. It's quick. And trust me, I've broken enough toes to know, with swimming, weird stuff, caught them on things and broke them. And I can promise you that toes heal quickly. So 3 weeks and you're good to go. Metacarpals are going to be more like 4 to 6 weeks. Same thing with the distal radius. So everything around the wrist is 4 to 6 weeks. But that's it, 4 to 6 weeks. That's not very long, right? So again, as we talk about distal radius and things like scaphoid fractures, wrist fractures, people get immobilized for too long. They don't need to be immobilized for that long for these kinds of fractures. Forearm, so radius ulna, 8 to 10 weeks, but humerus is 6 to 8 weeks. So really, that proximal humerus fracture, that shoulder fracture we usually call it, by 2 months they should be good to go. Femoral neck and femoral shaft are both about 12 weeks, so 3 months. And tibia is somewhere in the middle, so about 10 weeks. A burst fracture or a compression fracture of the spine, and actually probably extremities as well, is 6 to 8 weeks. But for patients who have osteoporosis, we're going to talk a little bit about that with this lecture. Patients who have osteoporosis, that type of fracture could take 12 to 13 weeks. So that's the longest period of time for a fracture, okay? Again, this is based on if there aren't complications of non-union, which we'll talk about in a little bit, some sort of malunion. If those complications don't exist, you'll see that every single type of fracture is pretty much healed at 12 weeks, okay? A lot of them are healed by 8 weeks. So 2 months, you are really pretty safe to do just about anything with a patient after a fracture, okay? It's really important that you have that in the back of your head, that these patients should be weight bearing, they should be loading, they should be doing these things, and they are really, really safe to do most things by 2 months. So what disrupts healing? We have different ways that we kind of label disrupted healing. There could just be a delayed union. That's one option. And that just means that whatever the area where the fracture was, it's taking twice as long to heal. So we just call that delayed. So it's lined up. Everything is happening. There's healing going on. It's just delayed. Okay. A non-union is also called pseudoarthrosis, and this means that there's no healing that's happening during the first 6 to 9 months. So obviously, like I said in the last slide, most things you're seeing healing relatively quickly, and they're completely healed by 2 to 3 months. In this case, there is nothing happening for 6 to 9 months. This type of non-union complication most commonly will be seen in things like the scaphoid, the femoral neck, and the tibial shaft. So those are the areas where we're seeing non-union. Again, probably because of blood flow issues. Malunion means that it healed in the wrong position. So it wasn't lined up correctly, or it moved somehow, and so you have a shift in the bone. Sometimes you can compensate for this during remodeling. So even if it's not the perfect alignment of the bone, doctors will say, okay, well, it's fine, because remember, that bone heals much more thick and much more solid. And so, okay, maybe it'll just keep growing. The bone will just keep growing, and it will grow that big, thick callus. And so it doesn't matter if it's not lined up perfectly, because it's going to still be a very strong bone. So unless there was like some sort of weird rotational problem or rotational fracture or a rotational malunion. So think of the femur. If the shaft of the femur somehow rotated, so the head of the femur, the head and neck of the femur are not lined up with the distal part of the femur, that is a malunion that they're going to go in and try to fix. So if it's not that kind of malunion where there's rotation, otherwise they're going to probably just leave it alone and say, okay, let's watch it and make sure that it just, builds up a really thick callus, and it should be fine. We don't have to go in and like re-break it or realign it or anything. What affects healing? Guess what? Smoking. Yay, we're talking about smoking again. So smoking will delay bone healing. I tend to see this the most with proximal humeral fractures. So shoulder fractures. We see a lot of patients, unfortunately, who fracture their shoulder and they're smokers. And oh my gosh, it takes forever for them to heal, and it takes forever for them to get their range of motion back. Diabetes, we've also talked about that one a lot. That's going to delay your healing process. Nutrition, if it's bad, it's going to delay. If it's good, it's going to help. Makes sense. I think we all know that. Physical stress. If it's the right kind of loading, it can help. Okay, so we say stress, but really we just mean physical loading, and it can help. But if it's stressing or it's causing the wrong movement patterns, it can delay. And certain modalities also might be helpful. So we'll talk about those modalities. Some sort of pneumatic compression could help with recovery of the distal radius. And so this was where they found that by doing some sort of compression to the radius, so the distal radius fractures we're going to talk about, that it actually did basically cause in faster healing. So this group didn't necessarily improve their range of motion, but they did improve their strength. So again, there's different ways to do modalities. There's different ways to do different type of treatment options to help with bone healing. And we'll talk about those even more. What I would say the most important thing is we have to think about with any fracture is weight bearing, right? So every patient wants to know, and every therapist should want to know, when can they start weight bearing after a fracture? So it's really important that you have these numbers kind of in the back of your head, these sort of standards in the back of your head with different fractures, so that you can make sure you can educate your patients on this stuff. The things that are going to influence weight bearing: number one, location of the fracture. Okay, location of the fracture meaning what part of something, like the tibial plateau. That's a big one that has a lot of issues with weight bearing. What part of the ankle, that kind of thing. And then how stable is that fracture by itself? And then if they did a fixation, how stable is the fixation? So you will have doctors, surgeons, as well as most doctors, who could spend 20 minutes showing you an x-ray and talking about the stability of the fixation. We don't need to know as much detail about that information. We just need to know that a doctor, a surgeon, is going to be thinking about that when they decide on their weight bearing. If they're not thinking about that, there's a problem. If the doctor is just saying, all of my patients after a hip fracture are non-weight bearing for 6 weeks, all of my patients after an ankle fracture, no matter where it is in the ankle, are non-weight bearing for 4 weeks, whatever, that's a problem. Sometimes surgeons are going to be way too conservative no matter what, but at least if they can give you reasons and justify why they're delaying weight bearing, I sometimes can say, that's okay. Another good reason to delay weight bearing or decide on certain weight bearing restrictions is their cognitive ability. So fractures happen oftentimes with older people because they're not cognitively 100%. And so they might not be safe, right? So they might be impulsive and, they get up and move when they're not supposed to. And so in those kinds of situations, doctors may put different restrictions on those kinds of patients. So you have to be aware of that. And as a therapist, that becomes a hard job for you. So you have to do a lot of patient education, family education, or caregiver education with those kinds of patients. So modalities, let's talk about those a little bit more. So we talked about the compression as being one of them. Another one is low intensity pulsed ultrasound, which we'll talk about in some detail, shockwave therapy, and vibration. So the British Medical Journal 2017 did a guideline related to low intensity pulsed ultrasound. And with this guideline, they looked at 26 different articles to provide their recommendations. And unfortunately, this particular guideline, looking at reviews, a systematic review, says you should not be using low intensity pulsed ultrasound for fracture healing. So if you are using it, I would reconsider, especially if you're using this as your primary form of treatment. It's probably not the best form of treatment. So this is just from that article, just kind of giving you the benefits versus the harms. And you'll see that there wasn't a significant difference with using it versus not using it. However, there is some research to show that shockwave therapy can be helpful. So extracorporeal shockwave therapy could be useful, especially for non-unions. So they say that the healing is basically their shockwave therapy can kind of jumpstart the healing process. And so that within 8 to 10 weeks of using shockwave therapy, they are seeing healing occurring. So this is one to consider. A systematic review from 2009 showed a 72% union rate overall for any non-unions or delayed unions. So the methodology it shows wasn't that great, but again, it's probably worth considering using if your patient is not showing good results with bone healing. So modeling and remodeling, as I said earlier, or I alluded to earlier, bone is really a dynamic tissue, okay? It's changing a lot. And so when we talk about bone modeling, it's that idea of reabsorbing and then formatting, formatting, suddenly can't talk, developing bone, okay? So it's some of the cells are being reabsorbed, some of the cells are coming to develop bone, okay? And you can literally change the shape of bone. You can remodel bone. So bone modeling is where you can change the shape of bone. Remodeling is where the bone just turns over, reabsorbs, but you're not altering the shape of bone. So you can actually, like I said, you can change the shape of bone. The best example that I can give of that is a pitcher in baseball. And I know you guys don't really know a lot about American baseball, but a pitcher in baseball has to do with their shoulder this huge amount of external rotation with the shoulder in abduction. And so you think about the glenoid of the shoulder, being this relatively flat surface, where there's a lot of movement of the head of the humerus around that glenoid. These people, especially when they're young, these pitchers, they are able to position their arm, because they're young and they're flexible, into so much external rotation, and they're doing it over and over again so many times that they literally get bone modeling. They get the bone. If you were to look at the bony alignment and positioning of the glenoid to the head of the humerus, it's different on that arm and it's different than other people. because they were able to do this modeling where they changed the shape of that joint, those bones. So bone cells are responsive to stimuli, okay? They're responsive to mechanical loading, but they're also responsive to other types of stimuli like hormones and minerals. So minerals being calcium. I know we talk about calcium a lot when it comes to bones, but our bones will grow, our bone cells will respond to different amounts of minerals as well as hormones and loading. Osteocytes, which we talked about at the beginning of this stuff, can sense and respond to those loads. So we have to think about, those are kind of the cells that we're thinking about the most when we're loading bone. Okay, so load is good, immobilization and bed rest is bad. I think we know this. We know that, instinctively, if you're laying in bed for periods of time, then your bone's not going to be as strong. If you are an astronaut on the spaceship, you guys, China's doing awesome stuff up in the space station, I think, right now. And there's no loading of bones. And so bones can become very weak. So they have to do these cool things that they do with exercise to load the bones so that they don't lose that muscle or that bone mass. So we have to think about that when we're thinking about our patients, and the fact that if they have been not loading and they've been immobilized, then they're going to have issues with bone growth. So this is also true with osteoporosis. Osteoporosis can happen because of changes in hormones and lots of other things. But unfortunately, our bones have the most bone mass when we're in our 20s. Like 25 is when we are like at our peak for bone mass and muscle mass, and basically most of the cells in our body are like the best at 25. Unfortunately, after about 25, everything starts to go downhill, including bone mass. So we start to lose bone mass, and then osteoporosis can be like a significant decrease in bone mass. So we can test this with bone density scans. I'm sure you guys have heard of these. They'll do them of the spine, of the pelvis, of the hip. This is a picture of looking at bone density. You can see the top part has that really thick cortical layer of bone, and you also have the trabecular bone is like there's more of it, right? So it's got these nice, the holes are there, but there's a lot of trabecular bone, and then there's like and then there's very thick cortical bone. If you look at the bottom picture, you can see the trabecular bone, there's a lot more holes. There's not nearly as much bone itself there, and that cortical bone, the outer part, is also much thinner. So that's what it can look like with a patient with osteoporosis. So you can see how that becomes an unstable bone. So Shanghai University of Traditional Chinese Medicine in 2016 looked at some rats. They looked at osteoporosis in rats. It always makes me sad when they have to give diseases to rats or any animal. This research was in kind of a strange journal called PLOS. I'm not sure if it's peer reviewed or anything, but it's still, it's research coming out of Shanghai, which I think is important. Basically, they looked at two different kinds of rats, actually, with osteoporosis after they did a fracture of their femur. And what they found was that basically healing time was increased for those rats with osteoporosis. So the rats that didn't have osteoporosis for their hip fracture, they were all healed less than 90 days. But the ones that did have osteoporosis, the fracture healing time was 94 to 98 days. So at least a week or 2 weeks, maybe 3 weeks longer than the ones without osteoporosis. So that's something definitely to kind of find out from your patients with any kind of fracture is whether or not they have osteoporosis, because it obviously is going to affect their healing time. However, on the flip side of that, osteoporosis can be treated. And there's lots of things to do. If any of you are working with patients with spinal fractures or anything like that, you're more than welcome to kind of talk to the leaders of this class, and I can share a great article about specific treatment that can be used for patients who have osteoporosis and get spine fractures. There's a nice little protocol that can be used, and I'll mention it in that compression fracture presentation, so you'll hear about it there. Osteoporosis has been found to be significantly decreased by doing weight-bearing exercises, using weighted vests, doing things that are low impact so you don't end up with a fracture. But, we talk about nutrition a lot with this patient population as well. So nutrition, vests, doing things that increase load, right? We want to increase load. That's going to help with osteoporosis, just like it's going to help with fractures. And other things that you can use, so we talked about nutrition and loading, but vibration has also shown some benefit for patients with osteoporosis. I know a lot of hospitals in China have the standing vibration machines. I know people just kind of randomly use them. I don't think there's a lot of research to show that it helps with a lot of things, especially sensory things. You might as well give it a try if you want to for sensory integration type problems or, sensation changes after stroke, those kinds of things. I don't know that it hurts anything per se, but there is some research to show that the vibration can help with patients who have a diagnosis of osteoporosis. It may help to strengthen bones. So the bone density, I guess most of the research has been looking at bone density at the hip, and it has shown to increase bone density at the hip. And what's good about vibration is we talk about things like proprioception. It can help with possibly increasing proprioception and decreasing risk of falls. So again, if you think about the whole, what's the word I want to use? The cycle of what happens with fractures is a lot of the time fractures are happening because of falls. And so you have a patient who maybe is diagnosed with osteoporosis. They are exercising like crazy to try to increase their bone density, but their balance isn't very good. So then they fall and they end up having a fracture. Whereas possibly if they'd done some vibration therapy, some treatment like that, with some other balance activities, then they might decrease the likelihood of falling, and then less likelihood of fracturing, right? So it all kind of goes together. We're going to talk a lot about some different fractures here. I know in China, you guys do a lot of rehab for fractures. I would say, fractures are not hard. They're really not. You need to understand the time frame. And there are certain kinds of complications that happen with different kinds of fractures that you need to just sort of be aware of, looking for those complications, that kind of thing. But I think you're going to find that fractures are pretty straightforward. There's just a lot of different kinds with a lot of different little nuances that are a little different with each one. So, all right. So that's your introduction to bone. And we will start playing with different fractures in the next recording.